Hi, my name is Jen Eisenbarth. I'm the Vice President of Administration at Baylor Scott and White Medical Center in Grapevine. I want to tell you a little bit today about oncology length of stay in our hospital and some opportunities that we had to reduce length of stay. Our average length of stay on our 20-bed oncology unit was higher than expected length of stay. This certainly presented a financial opportunity for us because reimbursement for inpatient hospitalization is typically paid in a diagnostic-related group, or DRG. So this means that the hospital is paid based on an anticipated plan of care as well as an anticipated length of stay. If it takes 3 days to provide care to the inpatient, the hospital is paid the same amount as if it takes 7 days to provide that care. The 4 additional days include a lot of additional costs that the hospital is not necessarily reimbursed for. So that being said, we had to consider a balance measure to make sure that length of stay was not inappropriately reduced to the point that patient safety or quality of care was suffered. Our interdisciplinary team chose to use the DMAIC model of define, measure, analyze, improve, and control to guide this work. Our average length of stay from June of 2016 through March of 2017 was 6.39 days. This was well above our expected length of stay, which created a variance to budget. We chose to measure 8 different diagnostic-related groups on the oncology unit to dive in a little bit more to see what we could learn about our length of stay opportunities. As you can see from this list, there are several diagnostic-related groups listed, and at the end of many of them, it says with MCC or CC. A CC is a complication or comorbidity. An MCC is a major complication or comorbidity. It's, for those who aren't familiar, it's basically a way to help ensure that we get proper clarity within the documentation as to the level of care that's provided. Because certainly if a patient has not only a digestive malignancy, but also has congestive heart failure or diabetes, or goes into respiratory distress while they're in the hospital, all of those things have to be taken into consideration and change the diagnostic related group, the expected cost associated with the care, as well as the expected length of stay. So also, for those who might not be familiar, there are certainly processes in place and safeguards that hospitals must put in place to make sure that upcoding does not occur to prevent unethical coding and billing. So our team engaged in 4 unique activities to analyze our performance and our opportunity. Our health information management team completed a coding accuracy audit, and they evaluated this to make sure we had properly captured our complications and comorbidities as well as our major complications and comorbidities to take credit for the care that we were providing and to receive proper reimbursement and length of stay goals. Our comprehensive care management team and our healthcare improvement team reviewed documentation for palliative care, as well as for avoidable days, because we wanted to make sure that our patients before and after the admission had proper care, because if we found opportunities, we certainly wanted to use that information and learn from it to improve our processes throughout the patient's hospital stay. Our nursing team reviewed standards of care to make sure that they had best practices in place and that their work was consistent from one patient to the next, which certainly impacts quality and safety as well as length of stay. Our utilization review team looked at coding and billing post-discharge to evaluate for opportunities for improvement in those areas as well. So what we learned is that, first of all, we had insufficient documentation regarding malnutrition, specifically severe protein calorie malnutrition. This documentation was sparse and did not clearly articulate the malnutrition to a point that it could be properly coded. This meant we were losing opportunity to capture those complications and comorbidities, as well as the opportunity to capture appropriate estimated length of stay, because severe protein calorie malnutrition would result in a longer length of stay expectation. So we were missing out on reimbursement dollars as well as expected length of stay accuracy. We also identified opportunities with our palliative care program. That program at the time was undergoing significant change due to the untimely death of the lead physician in that program. And our team identified that certainly that change and transition had a significant impact on our patients on the oncology unit, and as well as on our length of stay. Certainly primary concern was around quality of care for our patients, but a secondary outcome associated with that change in the team was a length of stay increase. The timing was great at this point because we were bringing on a new palliative care physician and advanced practice nurse. So we had the opportunity to take advantage of that new team coming on board to address some of these opportunities on oncology. Now, finally, we saw inconsistent provider communication regarding discharge planning. Patient understanding of the discharge plan and team communication among themselves about discharge led to inconsistent communication in practice. The inconsistencies and miscommunication led to delays in discharge and thus increased length of stay. To address the malnutrition documentation, we implemented a process by which our dietitians completed notes regarding malnutrition, which they had already been doing, but they took it one step further and flagged those notes for physician review. We started this work in May of 2017, and it really gave the physicians a better understanding of the severity of malnutrition, and it became an effective mechanism for increasing awareness for the physician, as well as then the physician's opportunity to list that diagnosis of severe protein calorie malnutrition within the diagnosis list. Doing this gave the coders the opportunity to go back and make sure that the documentation was properly in place by the physician to code for that additional complication. As we looked at our palliative care consults, as I mentioned before, with the addition of the palliative care physician and nurse practitioner, we were really able to quickly streamline a referral process that resulted in earlier and more consistent palliative care consults for our patients. In May of 2017, we also implemented unit-based rounds. This concept for our team was a 30-minute meeting to address and review all 20 patients on our oncology unit. It brought together our physicians, nurses, pharmacists, social workers, case managers, respiratory therapy, physical therapy, and dietitians to discuss barriers to discharge. That's the primary purpose for that meeting. And so with that intense focus and quick problem solving, we have saved hours of time that were previously spent with waiting for phone calls back from a provider, leaving messages, waiting on documentation to be in the medical record. The entire interdisciplinary team was together for 30 minutes where they addressed a lot of those communication barriers and reduced time wasted significantly. Finally, we began a pilot of a discharge planning communication tool in June of 2017. And that is a tool that hangs in the patient room and is updated by members of the interdisciplinary team throughout the patient's stay to ensure that all of their needs are addressed proactively prior to discharge, so that we aren't trying to do all of that patient teaching right as the patient is walking out the door. It really focused in on key areas for discharge, and again, along with the unit-based rounds, that communication tool certainly supplemented the unit-based round work. So what were we able to accomplish? We saw a significant decrease in our inpatient oncology length of stay. From the time of our intervention in May and June to the end of calendar year 2017, we saw a significant reduction. We reduced our length of stay by 1.55 days, from 6.39 down to 4.84. It's truly a remarkable decrease and speaks volumes about how change in process and reducing waste of time can significantly impact outcomes. As an aside, I worked on a length of stay project in a previous hospital where we were elated with a 1/3 of a day reduction in length of stay in 6 months, but came to realize that we had many more opportunities that this team in this current location took advantage of. And because of those well-evaluated, thought out, and implemented interventions, we truly found ourselves with impressive results. So to keep ourselves on track, we continue to monitor dietitian and physician documentation of malnutrition, as well as palliative care consults. That's something we do on a monthly basis. In addition, our leaders continually monitor unit-based rounds on a weekly basis to reinforce the standard scripting and meeting focus that we set in place when we started this program. We do that to ensure that our commitment to eliminating barriers to discharge remains the highest priority. The discharge communication tool has been the least successful intervention in this project. We didn't have adequate buy-in into the concept before implementation, and nurses really saw it as a duplicative piece of documentation rather than a teaching and tracking tool for patients. So at this time, we are evaluating whether we're going to tweak that intervention or discontinue it. So when we think about our cost-benefit analysis, what did we lose? We lost a lot of wasted time. We lost time waiting for phone calls back, waiting for documentation so that we would know what the next steps were in the patient's plan of care. That was our loss, was wasted time. What we gained were significant reimbursement opportunities and proper estimated length of stay by capturing complications and comorbidities. Our patients gained enhanced care in relation to malnutrition and palliative care needs because we were able to more quickly identify those opportunities, address them, and so that the proper team members could get involved that much earlier in the patient's stay. As we looked at sustained performance, we used the readmission rate as a way to evaluate as a control measure of sorts. And this was key, quite honestly, in my opinion, because as we eliminated waste and wasted time, what we didn't want to eliminate were key steps or milestones in the patient's progressive stay. Doing so could have resulted in increased readmissions due to not properly meeting the patient's needs prior to discharge. That's one fear that our entire team had as we started to address length of stay, that we would move too quickly and that our patients wouldn't get the care that they need before leaving and potentially increase our readmission rate. What we found is that we were able to sustain the readmission rate on this oncology unit while decreasing the length of stay by 1.55 days. And I have a couple of references listed here. One is our Commission on Cancer Innovation in Care report, as well as Evans and Lindsay, an introduction to Six Sigma, which was used as a primary foundation for the DMAIC model. I hope this was informative and helpful and certainly available for any questions. Thank you.